What are the risk factors for tardive dyskinesia?
There are quite a few risk factors, actually. I mentioned earlier that the same patient who develops acute EPS is likely to develop tardive. The reason is, it tells acute EPS means that this striatum, which is the part of the brain where there are dopamine receptors and dopamine neurons that are responsible for movements. When you stop the dopamine, you lower the dopamine activity to get rid of the psychosis,
Okay.
which is actually in another region in the brain. But the drugs go everywhere and they block the movement, the motor coordination movement center of the brain in the striatum. So that means you start having movement abnormality.
Okay.
All right. So that's why the same patient who develops acute EPS, it means their brain is susceptible to long-term EPS. Other risk factors, females more than males, slightly more, about 20% more. And then the long duration, the longer the duration of treatment, the higher the risk.
Okay.
So that's why after many years, even young people can develop it. And the dose, the higher the dose, the more the risk. So it's dose and duration, it's cumulative dose. And then you have the risk factors like having head injury or taking drug abuse or alcoholism also increases the risk. And then other risk factors have to do with the type of illness. A bipolar patient, mood disorders, not just bipolar, but also major depression, because antipsychotics are used for both. Atypicals are approved for both.
Okay.
This type of patient, the mood disorder patients who have depression, highs and lows, are more susceptible to tardive dyskinesia and schizophrenia.
Interesting.
Yes, relative. Schizophrenia still get it.
Yeah,
but
of course.
Bipolar get it faster. Depression get it faster. And then there's the issue of menopause. When a female reaches menopause and has been taking antipsychotics, she's much more likely to develop tardive dyskinesia. But aging in general, males and females with age become much more susceptible.
And the good news today is that tardive dyskinesia now is very treatable.
Finally, Bethany, about a year ago, we had a breakthrough and a new type of medication was approved by the FDA to treat tardive dyskinesia based on controlled double-blind placebo-controlled studies that companies have to do. And this was based on a new mechanism of action in the brain that actually reduces the amount of dopamine inside the presynaptic neuron. That turned out to mitigate and lower the risk of TD. It's an innovative mechanism of action, and that's what led medications to come to the market finally. Two of them came out in 2016 and 17. So we are delighted because now our patients finally have a treatment.
And hope.
There was no treatment before.
TD is a debilitating condition, but the good news today is that there is hope with new medications. The important thing is to watch carefully for TD, especially for people beginning new antipsychotic medications.
Yeah.
And if patients have symptoms, to talk to their doctor right away.
Absolutely. And all psychiatrists who tend to prescribe the majority of antipsychotics, we ask our patients every visit when we start an antipsychotic if they feel restless, if they feel stiff, if they have difficulty with some motor movement for the acute EPS. And then it's our job to observe them and look at their face and body and see if they're starting to have movements of the mouth and tongue and lips and jaw and eyes and grimacing, because that means tardive dyskinesia, most likely. And usually it takes several months to several years, depending on the patient, before TD starts. But we ask about the acute movement disorders regularly, and we test the patient and make sure they're not stiff and rigid. But over time, it is our responsibility to watch the patient's face and see if there's like movement that didn't exist before. So the earlier the diagnosis, the more quickly you can treat.